Good afternoon. I'm George Taylor. I'm a professor and associate dean for diversity and inclusion at University of California, San Francisco School of Dentistry. And I'll be speaking to you today about unconscious bias, health literacy, health and patient care as part of the PD 190 course. I'd like to acknowledge Dr. Linda Centauri and Dr. Sharon Davies as important people who have shared their knowledge as well as some of the information that I'll be showing in the slides that we discussed this afternoon. The educational objectives of this session will be to examine the dimensions of identity and how it impacts provision of health care. Also, I would like to use this session to describe concepts of unconscious bias and health literacy and their intersection in patient care and health. Before we go into a detailed discussion of unconscious bias and health literacy, I'd like to us to have a perspective on the demographics as of 2017 for the state of California. As you can see, the total population is almost 40,000, with 37% of the population being white, and as of 2014, Hispanic, Latinx, race ethnicity group has 39% of the population of California. You can see Asian population of 14%, and then less than 10% for the other racial and ethnic groups. Yet the population of California is quite a diverse population, and it's important to know that, and also we'll see how the population of California actually is changing over time. Next, we'll look at a slide of the demographics of the distribution of certain race and ethnic groups in San Francisco. Again, a diverse population, as you can see by the proportions of the various racial ethnic groups in San Francisco, as well as compared to their proportions and the distribution in the United States. This slide actually shows the changes in California up to projections of 2030 from the year beginning in 1980. As we can see, the white population is steadily declining. The Hispanic Latino population has had a steady increase between 1980 and 2030. The Asian and Pacific Islander population has also been increasing, while the Black population has diminished somewhat since 1980, and it's the change is very flat. There's not very much change at all. So it is with that broad context of the distribution of the population and its diversity in California that we will be thinking about as a major contextual feature for our discussion today. Now we're going to move and discuss social identity. Social identity is an important concept for us to consider when we have any kinds of interactions, particularly interactions as healthcare providers. There are many different kinds of social identities that are visible, and as you will see, some are visible or not, and others are completely invisible. But the list of identities here is a common list of identities. It's not all inclusive. And yet, these are important in any social interactions, how one identifies themselves and how we perceive their identity to be. So one approach is to look at a listing of social identities. This next approach is to look at the visibility or invisibility of social identities. As you can see in the pyramid, there are a number of identities that people may have that are completely visible, some that might be visible or invisible. And then at the bottom of this pyramid, you can see there are many identities that individuals can have that are actually invisible. And yet these are ways in which people will identify themselves and react in encounters. Now, what's most important about social identities is that they intersect. We usually have more than one social identity that is important to us. It might be, if you look at the inter circle, we'll see age, race, ethnicity, mental and physical ability, sexual orientation, national origin. And on the outer circle, you can see education, we can see political beliefs, family, income, religion. And as you can see, and as you think about, as we think about ourselves, we have multiple identities, and those identities intersect. And depending on the context, one or more of the identities would be important to us. And also provide the basis from which others classify and categorize individuals with whom they encounter. This leads us to bias, and thinking about how identity groups vary and how some identity groups are more marginalized than others. And in terms of bias, it will be usually a stereotype for one or more identities within a person who is a member of a certain group. And it's a prejudice. The prejudice could be in favor of, or it could be against one thing. It could be against a person or a group compared with another group, usually in a way, and usually biases are considered to be unfair. I would like to make note that, however, that bias can be also in favor of a group or other individuals. It's thought of as an unfair act or policy that stems from prejudice. And also, as I have said earlier, it may be held by an individual, group, or an institution. There are two types of biases. Generally speaking, one is conscious bias. This is very explicit. This would be similar to the signs that you would see in the Deep South many years ago, where the signs would be for separate water fountains or separate restrooms, and oftentimes you'd see a sign that would say "No color allowed." However, bias is the other type of bias is an unconscious bias. An unconscious bias, also called implicit bias, are biases that we have and express unconsciously or automatically. Oftentimes, an unconscious bias is one that is antithetical to our espoused beliefs, our espoused values, and yet they show up in certain circumstances that we will be discussing. Now, bias is not limited to an ethnicity or race. Racial bias and discrimination are probably the most well-documented type of bias. However, bias, as many of us know, can be towards a certain age group, a certain gender identity, physical ability status, sexual orientation, bias towards weight, particularly towards people who are obese, and many other characteristics. These two contrasting characters provide an introduction to a discussion that we will now pursue on how the brain has two contrasting systems that operate in regard to how unconscious bias is formed, how unconscious bias persists and reveals itself in our interactions and encounters with others. Our brain has two systems operating. There's a fast-acting system designed for efficiency, as you can see on the left, That fast-acting system presents with first reactions to circumstances and situations and encounters with others. It's fast, automatic, impulsive, operates by associations that have been imprinted in our brain, can be emotional and unconscious processing. It's in the limbic system of the brain. It uses small bits of information in sizing up a situation, task, or context from prior experiences or teaching, and is able to produce snap judgments of decisions and actions. It operates automatically and unconsciously. The slower acting system is our thinking system. It is conscious, reflective, deliberative, contemplative, analytical, rational, logical processing, and it is in an entirely different part of the brain, the neocortex. Let's look at some examples of activation of these different systems of the brain and begin to see how they might participate in unconscious bias. For the next few slides, write down or say what the instructions ask. Fill in the blank for the word that automatically comes to mind when you see this picture. Fill in the blank with the letter that automatically comes to mind when you see this picture. Say what you see here. Now say what you see here. If you consider the last three slides, you can see how quickly it took the context into account and quickly assigned very different meanings to the very same items. The difference was that they were seen in different contexts. Those were simple examples of your brain's fast-acting system working efficiently for you in situations of different contexts or different prompts. Read what you see on this slide. This is another example of the fast system of the brain recognizing patterns. These patterns come from previous experiences within the context of the no-nonsense word order and content of letters in each word to assign meaning to what you see. Sometimes the meaning is only apparent if your native language is English. Those for whom English is not their native language may not be able to decode the paragraph. Otherwise, if your native language is not English, the sentence might be nonsense. Again, read what you see on this slide. I'll give you just a little time to do so. Okay, this is another example of the fast system of the brain, the rabbit, recognizing patterns from previous experiences within the contents of the nonsense word letter order and content of letters in each word to assign meaning to what you see. Sometimes the meaning is only apparent if your native language is English. Again, if your native language is not English, the entire passage may be nonsense. Solve this problem. Clearly, the problem to be solved in this slide slows down our responses considerably. It requires a different type of thinking. It is thinking that requires us to slow down, be more conscious of the task, use more cognitive effort, and to be more deliberate and controlled before responding. This is an example of activating the brain system 2. The previous slides provided a context and recognized patterns or prompts that allowed us to rapidly and automatically respond without much, if any, thought or cognitive effort. This was our brain system 1, working on almost autopilot. Our response was based on prior memory and experiences as well as prompts and pattern recognition. If we think about the grouping of concepts on those previous slides, there was nothing inherently correct about the words we chose to fill in the blanks. They just seemed to fit based on previous exposure to these groupings and the prompts of the cooking pot or the bathtub. There it is to say, for the picture with the cooking pot, that was soup, S-O-U-P. And for the picture with the bathtub, that was soap, S-O-A-P. This slide reviews the major characteristics of the two systems operating in our brain. The Nobel Prize-winning economist Daniel Kahneman has written the book shown on this slide, Thinking Fast and Slow. This book provides a comprehensive description of the nature and workings of the brain's two systems and the implications for our judgments and decision-making based on the awareness of the operating systems of our brain. As you can see, the major characteristics of the brain are reviewed on this slide. As you can see, System 1 is very fast, unconscious, effortless, automatic, and uses associative memory. System 2 is slower, conscious, effortful, controlled, and deliberative. We'll next begin to explore the notion of blind spots, or hidden biases of which we are usually not aware. However, in operation, this hidden bias, or unconscious bias, or implicit association that can automatically show up in certain circumstances also can have major implication in the judgments and decisions we make or actions we take. Now, looking at common blind spots that are linked with identity. And here we start to link identity with the notion of unconscious bias. Note how unconscious bias can be triggered based on any number of identities that we perceive in other people, even if that's not how they would self-identify. This also can be complicated when aspects of individuals' identities are invisible. This slide relates back to the previous slides on the patterns or schemas that we assign to individual identities and connects to the next slide on implicit bias that we will be looking at. Social categories and stereotypes are kinds of schemas. We develop our generalized social categories or characteristics from many sources, including those listed here. Our parents, friends, media, school, direct or vicarious experiences, positive or negative associations, our background, our upbringing, our cultural, environmental, and personal experiences. Our social categories can either be positive or negative, common or marginalized. Example of positive categories are agents are good at math, professors are smart and are absent-minded. They also can be accurate or not. Understanding the inherent automatic nature of implicit social categorization helps explain implicit bias and its many aspects. Now, in beginning our discussion of social blind spots or unconscious biases, first let's consider a couple of striking examples. The first picture shows a schoolboy who is white and, based on his body language and expression, proudly showing his teacher a picture he has drawn. The comment on the picture is consistent with the teacher offering an affirmation of approval to the boy's drawing. The second picture differs only in the boy's darker skin color, and he is a boy of color. Notice the completely opposite reaction of the teacher, dramatically suggesting an association with something negative in the drawing and with the boy that requires a call to the boy's parents. Was the teacher aware that she was unconsciously treating the boys differently in providing her feedback? Could this have been an expression of unconscious bias? How do you think the teacher would have responded if they were asked whether they were biased against the boys of color in their classroom? These next two pictures depict the impact of media in shaping and perpetrating dramatically different associations and stereotypes about positive or negative behaviors by African Americans versus white Americans who are essentially performing the same acts. The first picture on top is a picture of an African woman wading through the flood waters, carrying a big bag and a large package. It says a young man, actually it was a man, not a woman. A young man walks through chest-deep flood water after looting a grocery store. The next slide shows two white people wading through the water with packages, and the news print says two residents wade through chest-deep water after finding bread and soda. Notice from a local grocery store after Hurricane Katrina. Notice, again, these people are doing exactly the same thing. The difference is in their color and their race and ethnicity. So then, what is unconscious or implicit bias? Using a formal definition. Unconscious bias is a construct characterized by immediate and automatic associations, as we have seen earlier, that we make automatically at an unconscious level. Notice that the cartoon is one where a woman seems to be interviewing with a man sitting behind the desk, while the man seems to be reviewing a document that could be a resume. The balloon of the male thoughts seem to be quite unrelated to the business-like scenario that the cartoon suggests. The man may not even be aware of this processing occurring in his brain, and yet might form judgments or make decisions about hiring or not hiring this woman based on the association in his brain that could be unconsciously being processed. Unconscious or implicit biases are triggered by our brain's quick judgments and assessments of people and situations. Their unconscious bias is activated involuntarily and without our awareness, and it stems from our natural tendency to organize the social world by creating and placing people of various identities in categories. Unconscious bias also characterized by social stereotypes about certain groups of people that individuals form outside their own consciousness. They are patterns or schema based on small bits of information. This is the fast brain working to process those small bits of information to quickly put people into categories or to stereotype them. Certain circumstances or scenarios can more readily activate unconscious stereotypes and attitudes. Examples of those circumstances include being under time pressure, under a heavy workload, or in a high stress situation. It's important for us to know that all of us hold unconscious beliefs about various social and identity groups. It's influenced by our background in growing up, cultural factors, environment, for example, the media, as you can see, what would happen if people were consistently exposed to the kinds of pictures separating the black and the white people in the Katrina news brief that we showed. And also personal experiences. Unconscious bias encompasses both favorable and unfavorable assessments, as I've said earlier. Now, the good news is that our unconscious biases are malleable. New attitudes can be learned that replace or override previously learned associations. We won't be able to talk about the methods for changing attitudes and to mitigating our own biases. And yet this is an important consideration when we're thinking about addressing unconscious bias. Next, we'll move into a discussion of health literacy and hopefully be able to link health literacy, health bias, and unconscious bias as we proceed in our discussion. As you see, this information comes from this Healthy People 2000, and it's a definition of health literacy. It defines health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make the appropriate health definitions. I want to say Healthy People is a program of a nationwide health promotion and disease prevention goals set by the United States Department of Health and Human Services. Healthy People 2010, as you see on this slide, launched an initiative to define and address health literacy as a major component in its national goal setting. And this then is the definition that Healthy People 2000 produced. There's a expanded definition of health literacy and linked to literacy, overall literacy, and it entails several features. It entails people's knowledge, motivation, and competencies needed to access, understand, appraise, and apply health information. It also entails being able to make judgments and decisions in everyday life concerning healthcare, disease prevention, and health promotion to maintain or improve quality of life during the life course. To address our national problem regarding health literacy, Healthy People 2020 has included a formalized goal with several elements as shown on this slide and the next slide. These elements focus on improving health literacy by increasing the proportion of individuals whose healthcare providers perform the following tasks with their patients. One is, what proportion of healthcare providers give patients easy to understand instructions? What proportion of healthcare providers have asked patients to describe how they would follow instructions? And thirdly, what proportion of individuals have healthcare providers whose office staff offer to help fill out a form? Here we see the Agency of Healthcare Research and Quality's 2007 survey results for improvement in communication skills in these 4 areas, as shown. That's 2.1 through 2.2. Increasing the proportion of individuals who report their healthcare provider always listened carefully, that was 59%, explained things so that they could understand, 60%, showed respect what they had to say, 62%, and spent enough time with them, 49%. The goal for 2020 is to increase each of these percentages by 10%. Patients and caregivers must be able to complete a number of typical tasks that require a reasonable degree of health literacy. To accomplish the task seen on this slide, a number of skills are required. These skills needed for healthy literacy include being able to access healthcare services, analyze relative risk and benefits, calculate dosages, communicate with healthcare providers, evaluate information for credibility and quality, interpret test results, and effectively locate health information. This slide lists behaviors suggestive of low health literacy skills, such things as asking the staff for help, bringing along someone who can read, inability to keep appointments, patients making excuses, such as I forgot my glasses, patients' non-adherence or compliance to medication, poor adherence to interventions, and delayed healthcare decisions. Low health literacy produces poor health outcomes in general, such as lack of health information, participation in unhealthy behaviors, delayed seeking of care, lack of appropriate care, higher use of emergency rooms, and that leads to higher cost of health care, greater risk of hospitalizations, poor compensation, poor comprehension of options, increased need for complex treatments, and greater risk of death. There are certain population groups that are at higher risk for low literacy and the poor health outcomes consistent with low health literacy. They include men, African and American and Hispanic, Latinx people, older adults greater than 65, those less educated, that is, less than high school. Again, to avoid stereotyping, these are statistically the groups at higher risk for low literacy, and yet not every individual in any of these groups listed necessarily are people who will have low health literacy. There are also specific oral health outcomes. These oral health outcomes have come from a meta-analysis of the relationship between low health literacy and poor oral health outcomes. The outcomes found on this slide are oral health specific poor outcomes. As one would imagine, these more frequently occur among vulnerable population groups. They include low health knowledge, harmful health behaviors, for example, sipping lemons, eating candy, eating high sucrose foods and candies, sticky candies, and other drinking, sugar-sweetened beverages frequently, increased emergency room use, elevated emergency dental care expenditures, poor oral health status in terms of oral cancer, in terms of caries, in terms of periodontal diseases, in terms of tooth loss. Factors associated with poor dental attendance are also associated with specific poor oral health outcomes. And then finally, reduced oral health related quality of life. An individual's oral health, as we know, is a function of a number of social factors as shown on this slide. It is these dimensions of social factors that play an important role in healthcare seeking by behaviors, as well as the provision of healthcare by healthcare professionals. What's missing on this slide are the other contexts in which the individual exists, such as the family, the community, the healthcare delivery system, the design of the financing and delivery of dental care in a particular state. So there's a broader dimension of oral health that influences each individual beyond the individual's characteristics as shown on this slide. This is a case study of early childhood caries to integrate health literacy and aspects of unconscious bias in order for us to get a sense of what occurs in certain kinds of encounters and what can be done to mitigate some of the unconscious bias that can occur. This mom has brought her child to see the dentist at her community health center as part of her well child checkup. Upon examination, the dentist sees several upper front teeth with cavities near the gum line and she learns from the mom that the child has been sometimes complaining that her teeth hurt when she eats cold food. The mom speaks limited English and reports that it is necessary to give the child a bottle with orange juice in it at night in order for her to go to sleep. When the dentist was providing oral health education to the mom and offering a plan for treatment for the child's cavities and home care actions for the mom to take, including switching from orange juice to water in the bottle at night, the mom resisted. She told the dentist in broken English that her child makes too much noise when crying at night, and the orange juice seems to soothe her enough to soften her crying so that it does not wake her other children. She also tells the dentist it's been a long time family tradition to use orange juice in a bottle to help children go to sleep. Additionally, the mom tells the dentist that she feels treatment of the baby's teeth is not needed because they will fall out anyway, and there's no need to control the amount of sugar-sweetened beverages that her child consumes. With that scenario, what are some of the ways unconscious bias by the dentist and low health literacy of the patient could intersect in this scenario? Well, the dentist could have a reflective response to speak louder because of the mom's limited English. The dentist may be assuming unconsciously that the mom does not have the same intellectual capacity as she does, and therefore needs to speak louder for the mom to understand the dentist's recommendations and instructions. The mom may be acting as though she fully understands the dentist by nodding her head in agreement when in fact she is not really understanding much of what the dentist is telling her. Next, we can consider what are some of the ways in which the dentist could make this a more successful encounter. The dentist could become self-aware and ask herself, what is it that she is assuming about this patient? Is she assuming that the patient isn't as smart as she is? Is she assuming that the patient has inadequate ability to care for her child's needs? Is she assuming that the patient doesn't understand the impact of oral health status of her child if the disease is not treated and adequate home preventive measures are not taken? Another consideration is it would be beneficial for the dentist to be conscious of what potential pathways the dentist is already assuming are occurring in her head and use a conscious approach in working to subjugate what might be an automatic processing of that individual mom. Tell me what dental caries means to you. Following the mom's answer, the dentist could ask the mom to tell her, how is this important to you? It would be important for the mom to articulate how her child's oral health is important to him or her. Also, the dentist can ask the mom, what do you think would be important for you to say in stating that you want to take care of your child's cavities and prevent new ones from occurring? Is this important for you, and why is it important? If there's a language gap and it is an important issue, the dentist should request an interpreter. So all in all, health literacy should be an integral part of the healthcare provider's clinical skill set. Health literacy means how can clinicians more effectively be able to connect to people who are their patients and who are relying on the healthcare providers to give them the best information and to help them make effective preventive therapeutic decisions for themselves and those under their care. So in this session, we've examined many of the dimensions of identity and how awareness of their visibility or invisibility and intersectionality can be important in connecting with patients and providing effective health care. We've also examined concepts of unconscious bias and health literacy, their intersection, and the need to address both in patient care and health. Thank you for your attention.